Today I'm going to talk about CT perfusion in stroke imaging. As you may have known that there is a revolution going on for stroke management. In medical field, it's rarely you use the word revolution, and then there is a revolution happening for the past few years. Basically, for treatment of delayed stroke from 6 hour to 24-hour, used to be a no treatment, poor result. Now with effective treatment, great result. The current thrombectomy, if going through the algorithm that patient get treated by thrombectomy, every two patient get one of patient will be uh, having great result versus uh, medical considered other specialty consider a great result is like 1 to 10. Every 10 patient get a one good result. That's considered a good therapy. For example, under 6 hours, IV TPA is 1 in 7 or 1 in 8 patients get a good result. That's considered a standard therapy and considered the best therapy we have then. Now, there's this tremendous improvement. That's why we are trying to implement it as soon as possible to benefit our patients. One of the study is called Dawn trial. Uh, this trial is for 6 to 24 hours, and then the other one is called the Diffuse 3 trial. The Diffuse 3 trial is the more recent one, from 6 to 16 hours, and the largest patient selection. And I discussed with Dr. Albers today and clarify a lot of the understanding so we can implement it. So this revolution happens. To give you an analogy, the internet is a big revolution. In 1996, internet was invented. There's a lot of hype about internet that result in year 2000. So many websites popping up, and eventually they have a .com bubble burst. So that is prematurely assuming the internet, the result will be harvested, and turn out that at the time the software and hardware not supporting uh, many useful application for internet. So there's a .com bubble, a .com bust. Now the internet is really showing its value. Same thing with CT perfusion. In year 2008, that was the bust, at least in locally, that the traditional teaching we're following their traditional teachings. The algorithm did not work. The software that we used called Vitria didn't work for CT perfusion, and then maybe now also there's a hardware device called Mercy device that didn't work for clot retrieval also. Now we have better device, and that result in a clear benefit for the patient using current thrombectomy protocols. For our hospital, right now, we do not do the hospital that's south of us, even though it's our sister hospital, we will not do their patient. We're just starting doing our own patient for now. So here's the float algorithm for the float. Uh, Patient came in with disabling stroke symptom. Here is a definition of disabling. And I think you can go with an NIH score of 6 or above. That is from my experience reading other articles. They're saying NIH stroke score of 6 or higher, basically mild to moderate stroke. They activated. They activated stroke 3 code. This activation of stroke code is the same as within 6 hours. So basically, it's really a it's physician signal to their own nurse and uh, to mobilize them to help with a stroke patient. But within 6 hours, they would not order the CT perfusion. If they order CT perfusion, that means they are fitting this window, 6 to 24 hours. So if you see a CT perfusion, that's for sure within this protocol. Anyway, So if there is a disabling symptom present, then different people have different roles. Our role as radiologists review the CT and CT perfusion and CT angiogram. I'll emphasize how to read them best, and to mainly determine the present or absence of large vessel occlusion. We are looking for clot in the internal carotid artery and M1 segment of the middle cerebral artery. That's it. Anything else is just uh, cream on the pie, and this is the most important one is um, anterior circulation big clot. Of course, when you see a M2 segment clot or basilar artery clot, you want to report it, but this is what we're really looking for. Looking for clot, we're looking for blood. If patient already have intracranial hemorrhage, we cannot do it. Um, so that's the exclusion criteria. And clot, blood, and then we're looking for infarct core. Infarct core will be generated by the Rapid software, which is under 70 milliliter right now is our cutoff, with the understanding that we're pushing it out to maybe 100 or more, because right now our current criteria is so stringent that there's so much benefit that um, clearly we're excluding a lot of people that could have been benefited. To push the envelope, they have to push the different criteria, the filter that we filter the patient. One of the way to loosen up on criteria is include more core infarct volume. But with that understanding, our current cutoff as of February 28, 2018 is 70 milliliter or less. And we make 3 reports, one for CT, non-contrast CT head. Second report is a CT perfusion report. And third one is a CT angiogram report. The clinician, they are really looking for the CT non-contrast report and the CT angiogram report immediately. And the CT perfusion report, more than 90%, most of the general radiologists after training with the Rapid software should be able to give. And if there's questionable case, they can leave it for the next day, and neuroradiologist can read it, because CT perfusion decision would not be made by the general radiologist alone, because neurologist and the neurosurgeon and also interventionalists, they're all reading it. So this is a joint effort. If when in doubt, they will just not do it, not treating it. So that is the bottom line, and we make 3 report, and then we call the ED 3 times. Actually, for the non-contrast CT study of the head, it's not critical anymore, because the ED, the non-contrast CT is, call report is not as urgent, because it's not like a decision to give IV TPA or not, because patient's already outside the 6-hour window. Patient would not receive IV TPA. Therefore, you could combine the CTA and non-contrast CT head report into one phone call to the ED. Versus within 6 hours, you would not see the CT perfusion, but you will have to call early for the non-contrast CT, because that will make a decision. The ED will make a decision based on the result to give IVP TPA or not. So this is the part that there's for making decision whether to go to thrombectomy or not. First, you got to have a big clot, and big clot means ICA distal and MCA, M1 segment. An aspect score of greater than 5. Maybe in the future we'll push it to include 5. Now that's a future research, and it's not what we're doing right now. Basically, for every point you see on the aspect map that you subtract, that's considered a stroke, finished stroke. For example, here, this is called finished stroke. This is not finished stroke. Therefore, do not call this aspect score liberally. Means a little subtle loss of gray white. You do not want to liberally give them the liberally take points off the aspect score. That patient would not receive this thrombectomy treatment. So basically, anytime you take more than 5 points off, actually take 5 or more points off, then you really check, are you sure about that? Because that means the patient would not get this thrombectomy treatment. What I mean is, look at this case. This case is our regular CT window. We did not window with so high a contrast, that subtle difference in gray white, you were calling it a subtle loss of gray white matter distinction, and you take a point off. Do not do that liberally, because that just add up could harm the patient by if you're adding up too much fast. And also you want to tell them where they are, because the 4 point here, which is the head of the caudate nucleus, internal capsule, both anterior limb and posterior limb, putamen, and the insular ribbon. This 4 point are all in the perforated artery. They are provided. They are supplied via perforator vessels. That if you don't see a big clot in the ICA or MCA, then you can't do much anyway. You can just do versus if you literally see a clot that's in M1 and M2 segment, then you can do something. Basically, we're trying to see whether we have any job for the interventional people to do. A separate point is that whenever we see this hypodensity, clear hypodensity, that's considered finished stroke. But basically every point we take off from aspect score is the point that we say this is finished stroke. Means there's no more hope of recovering it. Means we're calling that core infarct from non-contrast CT. That means if there is some confusion point about the infarcted core, whether you image too late or too early, then you use this non-contrast CT as a gold standard to check whether your CBF map is correct or not. Say the patient move or some other confusing point, use the CT as a guide to see whether this is finished stroke or not. Okay, go back to the criteria. We see the big vessel, blood clot, we look at the aspect score, we make sure there's no hemorrhage, we make sure the core infarct area is under 70 milliliter. We talk about the mismatch ratio, means we have to get big enough penumbra, means the penumbra means the semi-dead tissue that's going to be dead but it's dying, that's we're trying to save. Those tissue got to be at least 1.8 times bigger than the core dead tissue already. So therefore, you are going back to the core area, and then how do you make sure that core area is correct? And then you use, again, I told you the non-contrast CT head to verify. So this mismatch got to be 1.8 or above, and the minimum penumbra volume of 15 milliliter. It basically means that we got to have enough dying tissue for us to worthwhile doing the procedure. Otherwise, if the volume is too small, then it's not worthwhile doing a procedure for that. Basically, our job is to make sure the rapid software spitting back the number here is reliable. I was told by the investigator for diffuse 3 trial, he said that for a bigger medical center, that the stroke team usually have a discussion between neurologists, the radiologists, and the interventionalists. So therefore, a lot of cases happen in a gray area. That's not what one will happen to our community hospitals. We want to follow a strict criteria, which is here. about the patient head tilting during the CT scan. Head tilting does not affect diffusion, CT perfusion image qualities. They still, the map is still valid. The motion does affect the quality. That's why we want to look at the graph, for the motion graph, and make sure the patient's not moving too much. I mean, motion means this. The red is arterial inflow curve. The blue is venous outflow. This is motion. A little bit of motion is okay. It's not zigzag. If a motion happened from 0 second to say 25 second, affecting the red part, the red curve in the upslope part, then the quality will be really bad and probably not a useful study. Basically, it's non-diagnostic study. About 4 times in a year, this Dr. Albert said that he had to manually correct what the software mistake. For example, they automatically labeled the arterial inflow area into the eyeball, and then obviously you will see the whole brain is the colors all wacky and it's not correct, and you have to go back to correct it. Very rare, less than 1% of the case have that. Most of the case, computer correctly identified the arterial inflow area. Basically, most likely it'd be a MCA or contralateral, ipsilateral, or ACA. The computer find this area of interest by detecting which vessel have the highest, have the earliest and most strongest blood flow to that area, have the strongest, the fastest slope going up in the radiopaque density curve. So they will select that dot as the arterial inflow function reference. And then the same thing for the venous part, like this. For example, here they chose the this dot as the arterial inflow dot, and then choose this part for the blue part for the venous outflow part. So that's it for the motion. If a motion here, I have to discard. Motion here, we can tolerate. This is a mini CTA that's generated from the CT perfusion images. CT perfusion is first injection, then you do the CT perfusion, and then the second bolus you do the real CTA. You cannot do the reverse because if you do the CTA first, then the contrast will stay in the blood for 15-20 minutes. You cannot do CT perfusion after CT angiogram for 20 minutes because they will screw up the data because the previous contrast stay in the brain will confuse the software. This map is the mini CTA map, which is from the CT perfusion data. If there's some vessel here, of course it's not totally black. That means there are some collaterals. It's better than nothing there. But we cannot use this as a definitive guide. We will use Tmax 10 second as a rough approximation for the availability of the collateral vessel. If the Tmax 10 second means the bolus arrived really late, for those areas that the brain probably is dying, it's almost dead already because it takes that long to get to that area, to get to the whatever injured area. If the Tmax 6 second and Tmax 10 second is similar in size. Hold on, no, that doesn't make sense. If the Tmax 10 second, but sorry, this is the case that I'm talking about. This is from Diffuse 2 trial by the same author, not Diffuse 3 trial. This is a case of MR perfusion. Let's treat it as a CT perfusion because we don't do MR perfusion. So basically, the patient came in here with a stroke and with relatively smaller infarcts at time 0. And then the red area, that red means Tmax of more than 10 seconds, is moderate. And of course, the Tmax 8 seconds is yellow, Tmax 6 seconds is green. The whole brain is pretty much on the left side, it's all hypoperfused, and some area are worse. And then after this study, they did a regular cerebral angiogram, showed poor collateral, and there's no and recanalization was not achieved, no recanalization. And I had follow up with another MRI 3 hours later, showed there's a lot, even more, basically pretty much all the area of hyperperfuse are longer than 10 seconds. Therefore, this one doesn't have much, just they go hand in hand. The red go with collateral. If the more red you see, the less the collateral. That means better not wasting your time transfer from local small hospital to a stroke center because there's not much time left. There's not much uh, hope left because of lack of. The more collateral you see, the longer window that patient has to come over for treatment. This is just a later result. For now, we do not have to answer this question because we're not doing this perfusion study in our local community hospitals. One of the confusion point is about the delay dependent and delayed independent evaluation. Here, this case, they showed a delayed independent. Basically, this is the same patient, okay? The window is differently. The MTT, mean transit time. If the blood is getting through to the brain, that is chronically M1 segment occluded, but somehow got there, that means this patient have a good collateral. Brain is not dead, and the patient is asymptomatic. But because of the delay in getting there, the blood getting there, the Tmax show up. And the MTT, if you just because the blood is getting there late, it doesn't mean the brain is staying in the blood is staying in the brain a long time. This means arriving late, stay in the normal time, and still get out. So therefore we should not call this patient acute stroke because of the way it was presented because of the map. So what is shown is do not use this map because this map will make it look like a mismatch and brain is under ischemia. Use this map, they call it delay independent map. This map shows us more accurate result. The brain is no ischemia, just getting there late through collateral, so good collateral vessels. This is the point they want to drive the home with. I still haven't completely figured out the dependent and independent thing. I will keep looking further. But look at this case. This is in 2012. Where is that? Let me see. 2012. RSNA article. Evaluation how accurately the CT perfusion analysis software, how they're doing, including the big shots such as a Wintermark. But their result is the digital phantom readily evaluate the accuracy of CT and MR perfusion software. All of them have delay-induced errors and or insufficient correlation with true values. So basically, they sucks. So basically, anything before 2012 is not very useful. They evaluate the following softwares. The only better ones are T2, this one, and the NPM2. And then the rapid software was in there too, still not good result. So just don't rely too much on the CT perfusion. It's just genetically very noisy and not accurate. Another point, for the low cardiac output patient, for example, the red curve is slowly going up high like that. Just remember, this is a better vessel that computer automatically selected, either the ipsilateral or contralateral side. If that was selected on the contralateral side, then the vessel that incretion will be even worse. So you have to say that there's low cardiac output. You can consider global hypoxemia. That means thrombectomy is probably not useful. This one is the rapid they're working on. This one's already available in Europe. They automatically generate the score for you to get the aspect score. Right now we don't have that. We basically use our eyeball to generate it. It's currently being under FDA approval. If that is approved, then it's easier for us to generate aspect scores. Again, the bottom line is we use CT perfusion to give a rough idea of where to zoom our intention to and then scrutinize whatever vessel supplying that area, including M2 and M3 branches, because we are concentrating in that small area. We should be able to follow each individual branches. And also we are changing our CT protocol to make it 2 millimeter thick and 1 millimeter gap to make the vessel easier to follow. The tech will spend more time and then there will be more picture in the packs, but that is very easy for us to follow the vessel versus the previous jumpy pictures. This is required by ACR, and the hospital has been reluctant implementing it because the tech have to spend 5 extra minutes to doing that. But it's important, and one of my colleagues is comment on it, and it's making sense. This is example. On the top is the CT with slab that 2 millimeter thick and slab that going through the same area. The other one is not. Without, take a look.
This is, yeah, go ahead. This is the 2 overlapping 1 sub-millimeter MIPS. Mm-hmm. And here we can see, scrolling back and forth across here, that the vessels all line up beautifully. Mm-hmm. You can see these vessels lining up. As we go down, you can see this vessel beautifully falling all the way out. Okay, go ahead to the other. Now on this one, you can see it jumps. You can't follow the vessel. Each click, the vessel comes and goes into this frame of view. Same with this. See it, now you don't. Now you see it, now you don't. Where? What are you talking about? This vessel right here. Okay, go ahead. See it, now you don't. Now you see it, now you don't. Okay, the other one? And then the other one, you see it, and you see it all the way through 3 different cycles of the mouse click. See that? Mm-hmm. Okay. And because it's 2, it's still smooth. There's no increased noise. Okay. So now you can still see the same resolution, actually a higher resolution with the same thickness. Oh, okay, let's change it. Okay, thank you.
So basically, this is the reason. If we don't get what you're seeing now, asking for it. Another thing is we will do the basilar, not the interventional, we'll do basilar artery clot. Doesn't matter what time, even beyond 24 hours, because that if you don't do it, the patient is dying. And also CT perfusion is not good for posterior fossa. They cannot evaluate the brainstem or midbrain well at all. At best, give you some cerebellum changes. So that's why nobody using the posterior fossa aspect score system yet, because our images are so crappy due to the skull base beam hardening and difficult to penetrate that area. So for now, we just basically use Tmax 6 second as a representative of penumbra. Use CBF less than 30% as representative of core volume. So for now, the CBV map, we don't use it. The instructor said something about CBV map is it's a helper sequence if it's really low in CBV, and then do not treat it. But anyway, that's not in our part of the protocol. We don't use the CBV value at all. So we use CBF. So CBV, to forget about it, then TTP, and also not very useful. So CBF and Tmax, that's the main sequence. With the advance of thrombectomy now, the intra-arterial TPA, there's no role for such thing anymore. No IA TPA. Thank you for listening to this 30 minutes of whirlwind tour of CT perfusion.